And today we'll have Dr. Grunander come and speak, but just a reminder about our future meetings. Next week we'll have Dr. Fritzler come and talk a little bit more about financing your medical education, from taking out loans to the different kinds of scholarships and financial opportunities throughout there. It's a really good meeting for you to have a good idea of what you're getting yourself into, because I don't think some people realize that until it's like the time I'm at, actually, where we're about to have to actually start paying for it. It's different, so it's good to get subjected to it early on. And then the week after that, we're going to have Dr. Barb Trask's husband, Dr. Trask. He's a hospitalist, come and talk to us. And that'll be fun as well. So I'll just do a short bio of Dr. Grunander. I'll let her present herself more, but she's from Ogden. She went to Weber State for undergrad. She went to the University of Utah Medical School. And then she practices at Ogden Clinic, just up the street. And she's a general surgeon and has a fellowship in trauma surgical critical care. Correct? I didn't memorize that reading, I promise. And give her a hand and we'll have her present.
It's fun to be back. Lots of time was spent in this lecture hall and in this room, so it's exciting to be back. I have a little bit of a probably unique view on medicine and my experience going through medical school and residency. I'm married to a physician who is an orthopedic surgeon. When we got married, I had done 2 years of undergrad, and he had done 1. He had just gotten back from an LDS mission. And so we had several more years of school to go. He was also an athlete here. He was a track star here. So when we got ready to apply, I was ready to apply a year ahead of him. And so I only applied at the University of Utah. Don't do that. I don't highly recommend that. Because if he left, he was going to lose his scholarship in his last year of eligibility. And he didn't want to do that because of how well he was doing. And I, by some miracle, got in at the U. And so we moved to Salt Lake, and I started medical school, and he commuted back here to Weber State for a year. Well, then because I was there as a medical student, he didn't have a choice but to only apply at the U. Don't do that. He's phenomenal. He's way smarter than I am. And so he got in the first group of people they admitted. Come January, he was in, and just a phenomenal student. So we were both students at the University of Utah. I'll brag for him. He graduated #1 in his class. So that tells you what a smart guy he is. And I did okay. I was fine and in the top 4th of my class, and I was happy to be that. When it came time for residency, I knew I wanted to do surgery. And so just to give you an idea, general surgery residencies now for the most part are 6 years. It's 5 years of clinical training and 1 year spent doing research. And then a fellowship after that ranges anywhere from 1 to 3 years. So you're looking at a minimum of 6 years. Some places even have 2 or 3 years of research in the midst of your 5 years of clinical training. So you can be a resident and a fellow for 10 years. Yeah.
Do you just research during that time, or is it intermittent?
It's 1 dedicated year away from your clinical duties doing dedicated research. Now I'll tell you, I did mine different, and we'll talk about that as we talk about my training, but again, it goes along with how odd my circumstance was with my husband. But I knew I wanted to apply to residency, and I wanted to get started. So when we met with the people down at the U and the counselors, and they said, well, you know, most people would say take a year off and then do couples match. They have something available, kind of the same match that you go through for residency, but kind of dedicated for couples. And I said, no, we're not going to do that. I'm not sitting around. I hate research. I hate it with a passion. And I was like, I am not wasting a year. I've got like up to 10 more years of training. I'm not going to do this. So I went ahead and matched without my husband and matched at UCSF in San Francisco. Well, that still left him with your medical school to do. So we actually lived apart for a year. And your 4th year of medical school is pretty easy. You have some required stuff. You do a lot of electives, getting ready for applications. You take step 2 of your boards. You apply, but you have a lot of time off. So it was okay. We spent, I think, maybe the longest we ever went without seeing each other was maybe 2 months or 10 weeks or something, and then he'd come for a weekend or I'd come for a weekend, and I didn't really care because I was so busy. It didn't matter whether he was there or not because I wasn't home, so it didn't matter. So we lived apart for a year, and then when he matched, the plan was for him to just sort of match at UCSF, but that didn't happen. He matched at USC down in LA. And so then we're faced with, at UCSF it was a 2-year research program, so it's a 7-year residency. So we're faced with another 6 years apart, or what do we do? And so I was able, again, this just doesn't happen, I was able to transfer down to UCLA and not lose a year. I went straight as finishing my intern year at UCSF and went straight to UCLA as a second year. Because they had just expanded their program, and like it's just miracles. Anyways, and so again, now we come back to this research year. As a resident, I hate research, and they want me to do a year of research. And so I actually did my fellowship in the middle of my residency. Again, that doesn't really happen. Most people don't do it that way. And I did that during my dedicated research year, and I was a fellow for a year, and then I came back and finished my residency for 2 more years. And then we've come back here, and I practice here, and my husband did, he came back and did his fellowship at the U while I did my first year of clinical practice here, and then he joined a clinic at McCady, and I'm at Ogden Clinic. I'll tell you a little bit about general surgery residency. Some of you may be considering surgery. It's fabulous. I would do nothing else. But I think anybody that comes and rotates through, whether it was medical students while I was a resident, or I sometimes have some of you pre-meds that come and follow me in the OR and in my clinic, everybody that I meet, I say, general surgery is fabulous. I would choose it again in a heartbeat. There's nothing else I would be happier doing. But it comes with a price. Any surgical specialty does, but particularly general surgery and trauma surgery. And so if you get to like your 3rd year of medical school or your 4th year of medical school and you're like, ooh, I really like surgery. Surgery's so cool. It is cool. It's so awesome. But I really like peds, or I really like pathology. I'll tell you right now, do that other thing. Because you'll get about halfway through your surgical residency and you'll be like, oh my gosh, why didn't I do that other thing? Because I really hate my life right now. And even as much as you love surgery and there's nothing else you'd rather do, you're going to get about halfway through residency and think, holy cow, I hate my life right now. How did my life take a turn that it is in this horrible, awful place that it is? And surgery just never ends, and the demands never end, and your pager never goes off. I was on the phone with the ER as we were upstairs waiting. I'm not on call. One of my patients showed up there, so it never ends. But let me kind of give you a little snippet. We'll show you some pictures, and I'll give you a little snippet of what surgery training and residency is like, and then you guys can ask questions. Yeah?
When you say you hate your life, is that just, let me rephrase that. When you're in residency and you're saying it was tough, is it basically the time commitment that you just don't get to sleep, you get to see your husband? What makes it so bad?
Think that you know what feeling tired is like. You will have no clue how tired you can feel. So they have like this 80-hour work week for residents, right? You guys have all heard about the 80-hour work week and how, and even now for residents, for interns can't take overnight call anymore. Their shifts are 16 hours. If they're there for 24 hours, they have to have a dedicated 5 hours of no clinical work that they get to sleep and rest. I mean, it's ridiculous. It's stupid. Anyways, okay, so the 80-hour work week is really nice in theory. And a lot of places comply with it. My place did not. And I think it's hard to comply with it in the fact that, and I think if you think of it this way, you have 5 years to learn everything you're going to learn about the specialty you're doing. General surgery is huge. You've got to learn all about the disease process, all about how the decision making and clinical judgment about when somebody needs surgery and when they don't, and the timing of it. And then you got to learn how to operate. You got to learn how to be a surgeon. And then you got to learn how to take care of patients afterwards. That's a lot to do in 5 years. So just to give you a little peek into my life as a resident, my average work week was about 110 hours a week. You were supposed to get 1 day off a week, but some weeks, and more often than not, that 1 day came when you had been on call the whole day and the whole night before. So you came home when you were post-call and you were so tired it didn't matter, you slept and there was your day off and then you went back for another 7 days. The longest I ever went without 1 day off was 11 and a half weeks. Weeks, not days, weeks. I stepped foot in that hospital every single day for 11 and a half weeks. The longest I was ever at the hospital consistently, I went in on a Wednesday morning, I came home on a Saturday night. I did not leave that hospital for 4 days. I did not have a shower. I didn't have a change of underwear. I thankfully had a little thing of deodorant in my bag. I didn't have a change of socks. When my scrubs got bloody, I could get a new pair of scrubs, but I mean, like, I couldn't wash my hair, I couldn't brush my hair. I thankfully had a toothbrush. I mean, I was there for 4 days. And when you're there for 4 days, it usually means that stuff's going on, so you're not going home, and you're not sleeping. Or else you'd go home. If there was time to sleep, you'd go home. So I would sleep here and there for little hours or 2 at a time, but essentially for 4 days went without sleep. The way a standard call day would work, you would come in at 6 a.m., like your call when you're in-house, which means you're in the hospital, is usually like your trauma rotations. So you would pick the trauma pager up at 6 a.m., and that trauma pager was yours for 24 hours. We'll kind of skim through pictures, and I can kind of tell you what a normal trauma day would like as a resident. That was UCSF, and this is the University Hospital. This is San Francisco General. At UCSF, where I did my intern year, it was kind of split between a university tertiary setting where all these referrals came in and all these crazy cases happen that you don't see unless you're in a university setting. And then contrast it with half the year spent at San Francisco General, which is a county hospital. We don't have county hospitals here, and they're fabulous. And I'll tell you more about a county hospital because that's actually where then, when I went to LA, and you can leave that, oh, go back, you can leave this picture here. So this is Harbor UCLA, and this is where I spent pretty much the 5 years of my residency after my internship. This is a county hospital in Torrance, in kind of the south part of LA. If you know about LA and you know about gangs, our catchment area was Watts, Compton, and Southgate. Those people hate each other. I don't know why they hate each other, but they do. And so we would do trauma for 20 weeks out of the year. So 20 out of 52 weeks, you were, whatever level you were at, you were on the trauma service. And so you'd pick the pager up at 6 a.m., and that pager, whatever trauma came in, and then in addition to all the traumas, you also were responsible for all the acute care surgery problems that came through the ER. So an average day would usually consist of anywhere from 20 to 30 traumas and consults. As you became a senior level resident, you had to respond to every trauma. You at least would have a junior resident you could send down to kind of triage consults and figure out what was going on. You ran an OR by yourself with like an intern, and then you were the most senior level person in that whole entire hospital overnight. There was one attending in-house with you, but they slept. I mean, it was your job to run that hospital. Medicine didn't have help. I mean, you were the senior person running that hospital. So then you were in charge of the ICU. So you would have a 15-bed ICU with super sick trauma and surgical patients with an intern or a second-year resident running it. So everything that happened in that ICU essentially came back to you while you're operating, while you're responding to traumas, while you're just chaos. So then 6 a.m. could come soon enough, and like you'd be throwing that pager down the hall at your co-resident and be like, man, tag, you're it, I'm done. But you're not done. Because now it's 6 a.m. and you've been there for 24 hours and you haven't slept because you've either been taking care of traumas or patients in the ER all night, or you've been taking care of patients that are trying to die in the ICU, or you've been operating all night. We ran an OR 24 hours a day. General surgery and trauma had an OR that ran 24 hours a day, and ortho had an OR that ran 24 hours a day. And so if ENT or urology or neurosurgery had a case that they need to do, then they'd have to use one of our rooms, whoever was less busy. And truly, we operated 24 hours a day. Either doing gallbladders, bad appendixes, taking dead toes and dead feet off, because that was easy to do in the middle of the night, because if a trauma came, you could leave a junior resident doing that. Or doing trauma cases, exploring abdomens, opening chests, and I'll show you some pictures of that. So once you hit your 6 a.m., then it's time, you now have this whole inpatient service. You have a full ICU that you're in charge of, so you would go to the NICU rounds at 6 a.m. that would usually last for 2 hours. And then you have all your patients on the floor, all the patients you've operated on, or all the patients you've admitted that you maybe haven't operated on yet that may need surgery. At any one time, you'd probably have between 30 and 50 patients to round on. So your interns and your junior residents will have been kind of starting on things while you're in ICU rounds, but come 8 a.m., you still got to tell them what to do because they're junior level residents, they don't know what to do. So then you have anywhere between 30 and 50 patients that you've got to make decisions on, and then patients that have gotten sicker in the night that now need to go to the OR, well, the next trauma team's too busy, so you're there. So truly on average, when you would finish call, you'd go home. A good day was to get home by 2 o'clock in the afternoon. The average day was to get home around 4 or 5. And you'd be so tired and so hungry, you hadn't eaten, you hadn't peed, you hadn't done anything, you didn't care. Like you'd leave this trail of dirty, bloody scrubs, go into your bed, and then you'd sleep for 12 hours, and then you were back the next morning at 5:30 in the morning. And you'd work a day, and you'd usually do OR, and you'd do clinic, and then you'd come home for a night, and then you're back on call again, every third day. So that's kind of the life of a resident. There were services, which we would call like our elective services, when we would do colorectal, or when we'd be at a private hospital, a Kaiser hospital we rotated at, or you'd be at the children's hospital. And those were better, because you had a little bit more set schedule. You'd still take in-house call, it was a little less chaotic. Vascular surgery was always busy. People with dead limbs and ischemic limbs never seemed to come in the middle of the day. They always come in the middle of the night. So you'd spend all night trying to revascularize some leg, and then you'd have your full day, and so that was that. You just went without sleep. I remember like probably one of the lower points was when I was a chief resident, and I probably hadn't slept in like 3 days because I'd been there post-call until I think 10 or 11 at night, because just madness, and the other team need help, and just what it was. And like as I'm walking out, the trauma team's busy, and they're like, oh, can you see this abscess and just help this intern? You know, and you're tired. You haven't slept for like almost now, like, I don't know, 40-something hours, 30-something hours. You're like, where did my life take this turn? Like, I'm dealing with this drug user and this abscess, and you just don't know how tired you can be. And it's fulfilling and it's great, but man, you're tired.
So how did you cope with the stress during that time?
I don't think you have time to... It's just what you do. You lose sight of everything else. And this is where I think it's hard for people with, you know, I was married this whole time. My husband was a resident. In his residency, he was busy, but he was really, truly 80 to 90 hours a week. And he had a pretty good schedule. And he would be on trauma for only 10 weeks a year. So the other 40 whatever weeks of the year, he would go in on the weekend and round, but then he'd have the weekend off, and I'm nowhere to be found. So your loved ones have to kind of learn to deal and cope without you there. You miss birthdays, you miss holidays, you miss weddings, you miss, I mean, nothing exists outside of that hospital for the whatever time you're a resident. It just doesn't. Holidays go on. You don't even know it's Christmas. You don't know it's Thanksgiving. You don't care. Because all you can see is like the end of your shift when you can turn the pager off or hand it off. And so I'll show you just a few pictures here that you can kind of get an idea. Let's go through. Oh, this is just a picture of Cedars. So to contrast my county hospital. So county hospitals for patients with no insurance. We don't really have that here in Utah. If you showed up at a county hospital with insurance, unless you were a trauma patient, you got sent to whichever hospital was in your network. It truly is a hospital for patients with no insurance. It's funded by the state. And so to contrast that, this is Cedars-Sinai where I did my fellowship, also in LA. This part is just their critical care tower and nothing else. This is like 100-something million, billion, who knows, building that is just 8 floors of ICUs. And then you walk across these glass bridges and there's ORs on every floor. This building is the Max Factor building. Right next to it is the Steven Spielberg Imaging Center. This is all on Bob Hope Drive. They have like multi-million-dollar lithograph paintings just hanging on their hallway. Patrick Swayze, the year he passed away, was like roaming the halls of the 8th floor when he was sick and an inpatient. We took care of a lot of celebrities here, and so just contrast that, so much money versus like this hospital that takes care of completely uninsured patients. So this is my average trauma night, and this is why I love trauma. So some guy put his hand, we had a lot of factories and stuff in the southern part of Los Angeles. It was not that far from Long Beach, where they have a lot of the dock workers, and they do a lot of the loading of ships that transport stuff. So I don't know, this guy got his hand stuck in something non-salvageable, obviously, but. This was the year I was at Cedars-Sinai. I don't know if many of you remember, and probably not, because this was now a number of years ago, but commuter trains in LA and running between the north part of the valley and bringing them into downtown LA where people would work, but it's too expensive to live in downtown LA, so you live in the outskirts in the valley and you take like a 30-minute train or something into downtown. So there was a train accident that year, the Chatsworth train accident. The driver of the train, of this commuter train, was texting, and didn't see that the train was shifting and that the tracks hadn't shifted right and that another train was coming. And so he couldn't prepare appropriately. And so this is the chaos of what we call a mass casualty. So this was the year I was a trauma fellow at Cedars-Sinai, and we ended up getting about 20 of the patients from this. When they put the call in, this is a Friday afternoon, this is the commuter train taking all of the people home for the weekend, so it was packed. We had one ICU bed open, and that was it in our trauma ICU. Now there were other ICU beds open on the other floors, but in the trauma ICU we only had one bed. So it's amazing what can happen when you know we ended up getting about 7 critical patients and about 15 less non-critical patients who could go to a step down or a floor bed. And it's amazing how a hospital comes together and pulls together, and like none of our patients died, and it was great. So this is mass casualty. This is how we would spend a lot of our nights in the ER at LA, because again, we go back to those gang members in Watts and Compton and Southgate who really hate each other. So this is a guy that got shot in the chest and numerous other places. You can see up at the top, his chest is open. This is a chest tube coming out, draining blood and air from the chest cavity, and this guy probably died. Here's another picture of this is when we would do what we call a clamshell thoracotomy, when patients would get shot on both sides of the chest and they're like dying in front of your eyes in the ER. This is all done in the ER, not in the OR, because they're too sick to get them to the OR. And so you usually start by opening up the left side of their chest and evacuating blood, and you open up the pericardial sac around the heart, and you see if the heart's empty, and you manually do CPR on the heart. And then sometimes if you think there's too much blood on the right side of the chest and there's something you can control with the lungs bleeding over on the right side of the chest, then you do what you call a clamshell thoracotomy, and the whole chest cavity is essentially open like that. You clamp the aorta so that all the blood that you're giving goes to the heart and then goes up to the head, and you know that you make the abdominal organs and the legs ischemic, but clearly they're already ischemic when they're like this. This is the chaos of, this is what it would look like after you would leave the ER if you actually got the patient, if you could get them back to having vital signs and get them stabilized enough that you could actually go to the OR to fix whatever was wrong. This is kind of what it would look like when you would leave. And then one more. And then this is what they look like if they get up to the ICU. And so this is a patient with what we call an open abdomen. This is a patient that was so sick we do what we call damage control surgery, which means you can't fix everything while you're there, because the longer they're open, and these trauma patients, they get coagulopathic, where they won't clot their blood, they get cold, they get acidotic. So you do what you got to do to temporize things, and then you pack them and you leave them open. And so this is an open abdomen with an abdominal, they have these special dressings for these open abdomens. And then you would take patients truly looking like that to the ICU. And if they lived for another 24 or 48 hours, then you'd go back and see what more you could fix, and you'd usually leave them open, and they'd go back to the OR every other day, 2 or 3 times before you could try and get their abdomen closed. Here's another picture of a patient, open abdomen, intubated. You can see this huge scrotum down here. These poor guys, all the fluid just pulls where gravity is, and they get these bowling ball scrotums, and it's just horrible. You can see they've got lines and tubes everywhere. Their body's edematous. I mean, it's just disastrous. And it's so fun to take care of. That's why I love trauma. And I think that's the last picture.
Do most of these people die, or?
No, these guys, I have had lots of open abdomens that have lived. So you can stop that. That's the rest of the talk that I was giving. But that's just kind of a picture of what trauma's like and why it's so fascinating. I think we can kind of leave the rest of the time for questions. That kind of gives you an idea of what life is like.
How's the transition between residency and practice for you?
It's hard, because you've gone from always having this safety net of an attending's always there and around, to then going to being essentially by yourself. And when you come out to practice by yourself, this idea of this 80-hour work week, or 110-hour work week, that doesn't apply anymore, because nobody's there to like tag you're it. And we still do that. I think it comes down to really having good partners, especially in a surgical specialty. So I'm one of 4 general surgeons at Ogden Clinic, and then there are 4 general surgeons that practice out of a group at McKay. The group who has their office at McKay does all the call for McKay, and then my partners and myself do all of the call for Ogden Regional. So the way my life is now is I'm on call every Monday for trauma. It's a level 2 trauma center, which there's different criteria. All of the residency training programs are level 1. A level 2 program or a level 2 trauma center means that you don't have to be in-house. It means that I can take call from home, and I just have to be able to respond to the hospital within 15 minutes. And that's nice. I have a 2-year-old at home. I, not so secretly, have another one on the way. So it's really nice because I can be at home when nothing's going on. And obviously, this is Ogden, Utah. This isn't LA, where, I mean, at any one time, I could have 3 gunshot wound patients sitting in the ER, and like, truly, I have said to people, if you're alive when I get done with the sicker patient, then it's your turn to go to the OR next. And if you're not, I'm sorry. And you run off with the guy that's dying, and that guy's not quite actively dying yet, and you hope they're there when you get out in 2 hours, or 4 hours, or 8 hours, however long it takes you with the more critical patient. Ogden's a little more controlled. So it's not so bad. So I'm on call every Monday for 24 hours, and that is for trauma and then for general surgery things. Bowel obstructions, acute appendicitis, bad gallbladders, abscesses, things like that. And so that's also my main OR day. So I do scheduled cases on Mondays, which means I have scheduled gallbladders, I do hernias, I do a lot of colon cancer. I do a small amount of breast cancer. It's not my favorite, so I do a small amount of that. But any scheduled case that I see in my office, we decide they need surgery, I do that on Mondays. On Tuesday mornings, I do colonoscopies, and then I have Tuesday afternoons off. On Wednesdays, I operate at McKay. On Thursdays, I have a full day of clinic, and then on Fridays, I'm off. And then with my partners, I have 1 weekend of call a month, so that weekend is a Friday, Saturday, Sunday. That was last weekend, it was hell. So to give you an idea, that weekend was horrible. Last Friday, I went in and had scheduled cases that started at 7:30 in the morning. I finished those at about noon. A trauma patient got transferred from Brigham and Bound 1, got him sort of stabilized into the ICU, and then my partner needed help with a case that we finally started about 4. When his case was halfway through, the ER called me, another bowel obstruction had come in and needed surgery, so I followed that case and did another one about 7. There was a sick gallbladder that I took out around 10 at night, and then I went home and slept, and then Saturday morning I went in and rounded, did some more cases, went home for a few hours, got called back in the middle of the night for an appendix, and for another sick patient to get admitted. Sunday I had to go back in and round. I did a few more cases, went home around 2, went back around 10 at night, admitted a patient. Monday morning was a holiday, but I was still on call, and I went in and started a horrible colon cancer case that had come in over the weekend at 7:30 in the morning. Had another bowel obstruction I had to do after that, had a bad gallbladder after that, had an abscess and a drug shooter after that. Finally walked in the door at maybe 8 o'clock at night, got called again in the middle of the night, went out at 1. I mean, that was my 4 days of calls. So it's just, so now you're here and practice and surgery continues, and when you're on call, you don't want to call your partner and be like, I know you're on call next weekend, but I'm tired. So you just kind of got through it. But good partners is key. So I have fabulous partners, and we help each other. And I've got 2 partners that are at least 10 more years senior than I am. And even yesterday, something came through clinic, and I was like, this is what I want to do, but what would you do? Because it's not something we see often. So it's nice to kind of, you still have that safety net if you join a good group.
If you could go back, would you change your specialty, or would you do the same thing?
I do the same thing.
And if you could change anything that you did before, would you, or no?
It's hard as a female, and even for my husband, you know, we consciously made the decision to wait to have children, because I mean, who's going to raise my kids? I'm not home. I'm at the hospital 110 hours a week, and if I'm home, it was usually, like, you'd get home at maybe 8 or 9 o'clock at night, you'd hurry to eat dinner, and man, you'd go to bed because you're tired, because your day, I would leave my house by 5:15 every morning. And when you're a junior level resident, you have to get there even sooner, because it's your responsibility to like get all the patient's vitals from overnight and get everything ready for dressing changes on rounds. And so there were some mornings, man, you're walking in the hospital at 4:30 in the morning, and you're there for 18 hours, and you're tired. So that's hard, because you do consciously make a decision to delay having a family, and But I have a really good supportive husband who knew when we got married that that's what I wanted to do. I always wanted to be a surgeon. I never thought of anything else. Going through my third year rotations in med school, like nothing but general surgery was what I was gonna do. And he's really supportive, and you have to have a good support system. I mean, it's not like I can't have a chauvinistic husband that's like, I don't cook, I don't clean, I don't do grocery shopping, I don't do laundry. Like, it's a partnership. And we really have to help each other out. But I feel, I feel pretty lucky. Residency, as hard as it was, it's some of my best memories and my best friends. Even though we all live now different parts, like the 5 of you that start your class together and go from beginning on, we still get together once a year somewhere. We still talk and we text multiple times a month. I mean, they become your family because you don't have anybody else, and you have to help each other out or nobody survives. And so as hard as it is, like, I get like chest pain and like PTSD thinking back to if I had to be a resident again. Even that being said, like, it truly is. You'll think back on those 6 years and you'll be like, geez, that was some of the best 6 years of my life. Just because it's so chaotic. And like, people don't, and I don't think you appreciate it unless you're living through it.
I've heard a lot of stories like that, and I've asked myself, why do they make it that way? Does it come down to literally they just don't have enough physicians to staff it, or is it?
Partially, but it also goes back to kind of what I said at the beginning. You have 5 years to learn everything you're going to learn. And just because you're not in the hospital, like, one of my attendings would say, the best cases happen at night, and they really kind of did. And whatever hours you were away from the hospital, learning and surgery was still going on. And you get in this mindset as a resident too. Yeah, you've been there all night long, you've handed the pager off, but holy cow, one of your cases from the night just went bad and you've got to take him to the OR. That's a good case, and as a surgeon, like, you live on that and you thrive on being in the OR. So yeah, you haven't slept in like 36 hours, but you don't want to miss it either because that's a good case. And you don't want to miss a good case, and so you kind of forget that you're tired. And the other thing is I think you feel a commitment to your patient too. And you don't want to be like, here, I've taken care of this guy all night long, I've finally gotten them stable enough they can go to the OR, and you don't want to hand them off. Because like, that's like your project. And especially I think with trauma and ICU, these patients literally come in dying in front of your eyes. And you save them, and you get them better, and you don't want to hand that off to someone else, because like, that's your patient. And I think younger generations that kind of grow up with this 80-hour work week and the thoughts of 80-hour work week, I don't think always appreciate that. Like, that's your patient. That is your blood, sweat, and tears in that bed, keeping that patient alive. And so that's part of it too, I think, and it's just like the surgeon's mentality, if you have that mentality of being a surgeon, is that you don't want to miss that stuff. And you got to learn it while you're there. Because now that I'm out here, I can't, that case, that bad trauma that comes in the middle of the night, if I went home and slept that one trauma case, this random thing that you sometimes only see things once or twice in your residency, then what do you do?
The question regarding that,
Mm-hmm.
sometimes, when you have to stay up really all night for a test, sometimes I was telling these guys a couple weeks ago I stayed up all night for a test, and then I kind of felt like it actually was detrimental to me because I felt like my mind was such a mess that I just wasn't functioning properly. When you're up that long, don't you get some of that to where you're like, I can't function. I feel like I can't think.
I think you do to an extent, but I think studying for a test is different too, because you've got so much adrenaline and like you're running all around the hospital, and I don't know. You kind of, it's not until like you're sitting in your car like ready to go home that you're like, oh my gosh, I'm so tired. And I would talk to my mom at all hours of the day to try and keep me awake. I would call my grandma. I mean, like, I've stopped at a stoplight before driving home and fallen asleep, and like the 2 seconds you're stopped at the stoplight and like cars are honking behind you. And there are days where you were so tired when finally like your shift was over and you're in that mindset of like, okay, I'm done for a few hours, that I would sleep at the hospital for a few hours before driving home. But I think it's hard to explain, but once you get in it, you kind of, it's just, there's so much always to do. You never have that minute to just sit and be tired.
Could you elaborate on medical mistakes then? Because that's why they're restricting the hours, right? So that they limit the
But
amount
it's
of money.
interesting because now as they're looking at it, they're actually finding there's more mistakes with all the handoffs and with all the sign outs. With interns giving sign out every 12 hours, more things are getting missed and more mistakes are happening than actually having that continuity of care and having a little bit of sleep deprivation.
So do you think it's gonna change the restrictions eventually, hopefully?
I don't know, I was just glad the year that they changed the intern work hours was the year I left, and I was glad I was gone, because it's already hard enough having interns, like, trying to learn what to do and coming and going, because they always are coming and going. You as the more senior level person, you're there till the bitter end, and the intern was, you'd get to a point at the end, you'd kind of take sympathy on the intern and be like, all right, go home, I'll just see you in the morning. But they are finding more mistakes now because of all the handouts and all the sign outs, and the interns and the junior level residents aren't getting to have the continuity of care and actually learning the patients. So I don't know, it's gonna be interesting. It's now only in its third year of intern level stuff.
Could you elaborate on, I'm sure, every physician makes a medical mistake. Could you elaborate on how you or other physicians actually recover from making a mistake? Because I can imagine if I killed a patient, it would just break my heart. And so I don't know if you could just talk about how you overcome that and then go on to the next
I'm
patient.
trying to think, I've been pretty fortunate. I've never had something where I felt like I went home and was like, oh my gosh, I killed that patient. There's something I should have done differently for that patient. The only time I can think of was we had a trauma patient, and it was an anesthesia mistake, but that they just didn't call us soon enough, and I felt really bad because it was an 18-year-old kid that had been shot, and we'd operated on for 5 hours, and got the kid fine. He was going to be fine. He had a bunch of abdominal injuries, and we fixed him, and he was going to be in the ICU, and he'd be in the hospital for 2 or 3 weeks and go home. And the anesthesia resident, which was a junior level anesthesia resident, over-sedated the patient as we were leaving the operating room to go to the recovery room, and then the patient started desaturating in the recovery room, and he didn't tell any of us, so we didn't reverse him, and then he couldn't get him intubated, and we ended up having to do an emergency airway on him, and anyways, by the time everything got said and done, the kid was brain dead, which was really, really heartbreaking. But that was when I was like a 4th-year resident, and see, that was probably 6 years ago, and you still carry it with you. You just try to learn, and I don't know, I think that also goes back to not wanting to leave and leave anything to anyone else, because you feel that responsibility, and if something happens when you're not the one there, then that's a little bit harder pill to swallow than doing the best that you can. Every residency, whether it's surgery or not, has something that we call M&M, morbidity and mortality. So we would have M&M every Wednesday. It's horrible, horrible. And so any patient that had a complication, whether it was like your mistake or just it's something that was a complication after surgery that was out of your hands, you had to present at M&M. And every attending at your hospital in surgery is there, every resident is there, and I really learned early on. I'd rather learn from somebody else's mistake than be the one up there standing at their store. I tell you what, I paid attention every week at M&M, and you'd be surprised how often in the middle of the night something would be happening and you'd be like, holy cow, this could so be that. And you learn from someone else's mistake. Mistakes are gonna happen, and patients are not gonna do well no matter what you do. The one thing I think you have to learn going into medicine is that as much as you want everything to be in your control and in your hands, it's not. There's a lot of things that no matter what you do, the patient's gonna die no matter what you do. And there's things like you can totally screw up and not do the right thing, that patient's gonna live anyways. It just is how it is. And so you just have to learn you can only control so much. And even now, I've been in practice almost 3 years, and I have this guy I did this horrible colon cancer surgery on Monday. He's 81, and he's so sick right now. And the thing that's been the hardest for me to realize is that I didn't give that patient that disease. I didn't make him not have a colonoscopy for 20 years. I can only do the best with what I'm dealt with, and that's kind of help. And you just do the best you can. And I think the other thing that helps is you always have to know when to call for help. That's the biggest thing I think interns and junior residents make the mistake of, is wanting to take everything on themselves and wanting to show how good they are. And the worst mistake you can make is not recognizing when you need help and calling for help. And I learned that early on. If your patient's drowning and you're the whole ship's sinking, man, you want to pull your whole team on board. You don't want to be the only one on that ship that sinks with that patient, because then you're the one up there talking at M&M and they're like, well, what was the advice from your senior resident or from your attending? And you're like, I didn't call him. So you just watch this patient die and then call for help, and you just learn early on. You don't know everything, you're not supposed to know everything, and the best you can do is what you know how to do and then call for help. And that prevents a lot. That's a hard lesson to teach junior level residents. Yeah?
How grueling are they during that M&M? Like, are they pretty like constructive about it, or are they just
It
like?
depends on how bad the thing is that you did. I mean, there are residents that, I mean, people are human, and people are gonna make mistakes, and no one ever goes into surgery thinking, I'm gonna totally botch this and do this wrong so this patient has a complication. Nobody does that. I mean, bad things just happen. Part of it would come from how well you knew how to present. And I learned, I was a good resident, I'll brag for a minute, I was a really good resident, and I learned early on how to present and how to be prepared. And I think the more prepared you were, and you didn't go up and try to beat around the bush, you just go up there and you're like, this is what happened. And this is, like, you just tell it how it is, and it is what it is, and you're prepared with the literature, and you know your patient, and you usually would do okay. I mean, there were some gross errors. I mean, I had some co-residents that probably shouldn't have been surgeons, and that's in every program. You'll find people everywhere. Shouldn't be surgeons. My husband had one in his program. That shouldn't be doctors in general. And those people just have such gross clinical judgment, and they just don't know how to do things right. And those people got reamed out. But for the most part, if you're doing what you're supposed to do, complications are going to happen, and you get up there and you present it, and it is what it is, and you hope everybody else in the room can learn from it. But you do see people get reamed out, and you feel really bad about it.
As undergraduates, is there any advice that you can think of to give us?
I think you're always kind of looking forward to the next step, like, oh, I can't wait to start med school, oh, I can't wait to start residency. I think you kind of need to enjoy the step that you're at and learn what you can from it. Really enjoy med school. Med school's easy. I don't think you can appreciate how easy med school can be in comparison to everything. Med school's a great 4 years. But I think just approach everything with like, this, I have my 2 years of clinical to learn everything I can in bookwork about medicine, and just really be dedicated and think of every just step as, and I think if you think of it that way, it's a little more tolerable. I have 2 years to learn all this bookwork of medicine, 3rd year med school. I have this 1 year to really kind of get a glimpse of medicine and all these different specialties and kind of get a sense of how I want to spend the rest of my life. 4th year, man, just enjoy it, because it is a piece of cake, except for all the stress for matching for residency. That's horrible. And then residency, the day you walk into that hospital, just think, this is my home for 3 years if you do family practice or internal medicine or pediatrics, or 4 years if you do OB or radiology or pathology or something like that, or for 5 years if you do surgery or surgery subspecialty. This is my home. This is what I'm doing. And you just kind of have to ignore everything outside the hospital, and it becomes more tolerable. For us, it was really good to be away for residency, because then you feel less guilty about all the stuff you're missing, because if you're here and missing it, you feel kind of bad. If you're 2 states away and missing it, then, and you still feel bad. You know, my husband spent Christmases alone when he would be off, and I was at the hospital on call on trauma or revascularizing some stupid dead limb, like a whole New Year's Day that I spend, and then cut it off 2 days later, and you're like, well, that's a day of my life I will never have back, and that guy still lost his leg. But I think if you just think of it that way, like, I have 5 years to learn everything I can learn about general surgery, and kind of whatever you get to attend on the outside world is just a bonus. It makes it easier. It makes it tolerable.
I have another question. You're saying you saw some residents or some coworkers that you thought should not have been doctors or surgeons. Is there any signs we can look out for?
That guy.
No, I think you just have to, like, really know yourself and kind of know what your capabilities are and what you're willing to do. You know, like, the medicine residents didn't have it that bad. And I think if you want to do surgery, that is fabulous. But you've got to know, like, surgery never stops, and your patients never stop. And are you willing, personally, to give up that much of your life to do it? I mean, I was crapping in Philadelphia taking oral boards 8 days before I had my first baby. And everybody was like, you are crazy, you're gonna go into labor. My husband was livid. He's like, you are gonna have our first baby and I'm gonna miss it. And I was like, I don't care. Boards are only every 3 months. And if I don't take them now, I have to take them in March and it's not gonna be easier. And I was ready and like, life goes on. And it doesn't matter what else is happening personally, like your career just keeps going and you kind of have to just pull your personal life along with it. And it's hard to say, but it's just kind of true. And you just have to be okay with like missing Christmas and, you know, missing some Thanksgivings and missing weddings, and it just happens. And I think internally if you feel like, man, I just can't make that commitment to medicine, then that's fine. There's lots of other specialties you can do.
Well, if you don't mind me asking, what, I guess, motivated you personally to make all these sacrifices that took you through here?
My dad's a surgeon, and so I think that's part of it. I was kind of exposed to surgery at a really young age. But I will tell you, there's 5 of us children, and I'm the only one in medicine. And the other 4 are in business. So take that for what it is. But I just really, like, since I was 5 years old, I wanted to do nothing but surgery. And I loved the blood and guts, and I loved, this is why I'm a trauma surgeon, I love taking a patient that is dying in front of my eyes and watching them walk out of the hospital 2 weeks later, or 4 weeks later, or 6 weeks later, or whatever it is. And I love medicine, but man, I couldn't be a medicine doctor and sit in clinic all day long and hand out pills and hope patients get better. Like, I want this bad perforated colon cancer to come to me, and I want to be the one to whack out their colon and hook it back together and watch them get better. And I want to be like, I have to physically be doing something to make them better. And I think you'll find that it's interesting how 3rd year of med school kind of like divides your class. And like there's the medicine people or the non-surgical people, and then there's the surgical people. And like it divides out pretty quickly, and you kind of just know yourself how you are. Anything in medicine is a sacrifice. Don't let me downplay it. Medicine doctors still make plenty of sacrifices. But I think you love what you're doing enough that it kind of is okay. And life is better outside of residency. I mean, I work 3 days a week. I take 7 days of call a month, which isn't bad, but I take call from home. And so, you know, if it's not a trauma patient and they call me and they're like, we've got a 12-year-old with acute appendicitis, and I say, okay, I'll be in there in 30 minutes after I put my 2-year-old to bed. And I put my 2-year-old to bed, and then I go in and I deal with this appy, and like, so life is better. My husband has a pretty good schedule. I work 3 days a week, he works 4. He maybe takes, on average, maybe 3 days of trauma call a month. But otherwise, I mean, he leaves the house at 6 in the morning, and last night was a late OR and he didn't get home till 8:30. But most of the nights he's home by 6. And you can have some control of your schedule and you can cross off so you miss a lot less, but you still are taking call at nights and on weekends and on holidays because you have to take your fair share. But life is manageable outside of residency. It really is.
And on your days off, you do have to go around on your patients and stuff like Ogden Regional.
Yeah, except, so I have a really pretty good setup with my group. So like today's my day off. I don't do anything on Fridays. So I was in the hospital this morning and I rounded. I have 3 patients in the house. But for the weekend, my group works it so that whoever is on call rounds on all of the partners' patients. So I don't go in on the weekend unless I'm on call, or unless I have a sick ICU patient, because my partners don't do ICU care and I do.
Oh, okay.
And so then I'll go in and take care of my own ICU patient. Now the group at McKay, they don't have it set up that way. So if they have a patient in the hospital, they step put in that hospital every single day. So it kind of comes back to having a really good setup with partners and partners that you trust, because I have a life. Now my husband, he has to round every day. He does hip and knee replacements, and one of his OR days is Thursday. So the patients he operates on Thursday don't usually go home till Sunday. So he rounds every day, but he also has a mid-level that they split with too. But you make it work. But I have a great partnership. So really, truly, I work 3 days a week. And then that weekend that I'm on call, it's held for a weekend, and then like, so I went in this morning and round it, I won't step foot back in that hospital till Monday morning. Unless my partner needs help with something, then he calls me. So it's not so bad.
That's cool. When you finished your residency and you're about to choose your practice, was it easy for you to choose the practice you wanted? And I'm curious why you chose Ogden Clinic, versus, other
It was hard. Yeah, I had a job actually to stay as an attending where I had done residency at. And my husband had a job to stay at USC. And we debated, you know, we're both from Ogden, our families are here. My dad's a surgeon at Ogden Clinic, which is partially how I ended up back there. But it was hard. I interviewed with a trauma group down at IMC, and I started talking to the trauma group at the U. And what it came down to for me is that I wanted to have a family. And to be a full-time trauma surgeon, you have to be okay with taking 8 to 12 days of in-house call a month, where you're there for 24 hours or 30 hours. And for me, that was a hard pill to swallow, where I felt like I'd already really delayed having my family, and as much as I loved trauma, I didn't want to miss out on a third or a fourth of my child's life through the month. So that is partially what led me here, is because I could still do bread and butter general surgery, which I like. I do colonoscopies. I love colonoscopies. That's like an easy day for me. I still love doing laparoscopic colon surgery. I like fixing hernias. They're fun. And so I get to have a private practice. I get to have patients, and I still get to do some trauma, but I get to take call from home. So that's what it came down to for me. Yeah.
So you said that, like, you're okay with blood and guts, obviously, wanting to go into surgery, but was there a point where the trauma came in where you were just like, that's not right, and how did you get over it?
No, I think more than anything, it's probably the emotional stuff that goes along with trauma. These young teenage kids that are just so dumb and come in, early on as part of their gangs and gang violence. I think the worst thing I ever saw that truly, I just cried when I was done, was a mom that had shot her 2-year-old point blank in the head and came in, and then the 1-year-old came in shortly after. And so dealing just with the emotional side of trauma, but that's like guts pouring out and arms hanging off, that didn't bug me. So things in the eye bugged me. But that's when you would throw a towel over and be like, can you call off though about that? That's disgusting. The eye bugs me. But the emotional side of trauma is harder, and dealing with kind of some low life people. We had some guy that had killed his wife and buried her in the wall of their house or something when they were renovating it, and then when they found it 2 years later, he jumped off a cliff, and this guy would spit on us every day on rounds. I mean, this is the scum of the earth. That's hard. Is taking care of people when you'd rather be I'd rather just smother you with a pillow, because truly that's kind of what you deserve. And there's your blood, sweat, and tears on the bed, saving someone that had shot and killed a cop, which we did not uncommonly. People that had killed their family members. That's hard to swallow. But you do it because that's what you do. But that's the harder part of it.
I have a question about shadowing surgeons.
Yeah?
Have you had students shadow you?
Uh-huh.
So,
I guess there's something with the clinic that you guys can't come into the clinic anymore, but I have students that come to the OR. You can come to Ogden Regional,
I was going to ask you if
and you can shadow. Yeah, you have to call the medical staff office at Ogden Regional, and they have a paper that you fill out and that I fill out, and then you can't scrub in, but you can be in the OR and you can observe. And I'll leave my number, and you guys can text me. I'm there every Monday, and you guys are welcome to come and watch whatever silly thing we're doing that day. But yeah.
That's it. We'll
Okay.
give her a hand. Thanks.
Good luck to everyone. It's well worth it in the end. Oh, thanks. Okay, I'll just leave my number right here, so if you guys ever want to just text me, just kind of tell me who you are, and you have to kind of arrange it ahead of time with the medical staff office. McKay doesn't let you come in, but Ogden Regional
Is
will.
that do your email or whatever you prefer?
Uh,
You want 100 pre-med students calling you? Or
yeah, email's fine too.
whatever you prefer.
Yeah.